Good morning and good afternoon. My name is Dr. David Ayoub, and I'd like to thank first the organizers of this conference for inviting me to speak today. It's quite a privilege for me and an honor. I am a diagnostic radiologist at a private group in Springfield, Illinois. We're affiliated with Southern Illinois University School of Medicine, so we do have radiology residents, somewhat of a quasi-academic situation. And about 7 years ago, I had a rather unique opportunity to review skeletal surveys in suspected child abuse cases. I did this at the behest of a friend of mine who's a pediatrician. And what I'm going to present today is basically the cumulative efforts that myself and about 24 other individuals have undertaken in evaluating and studying these cases. What we have discovered is that much of these cases appear to be infantile rickets in a phase of healing. It's an ancient disease. I think it's a disease that certainly has been forgotten and underappreciated. And even in the time that this was an epidemic, I think early infantile rickets was relatively subclinical until something happened like a fracture and was somewhat underappreciated. The basis of my opinion and my presentation is basically largely a collaborative effort from Dr. Charles Hyman, who's a retired child abuse pediatrician from Loma Linda, who actively reviews these cases, and Dr. Marvin Miller, who's at Wayne State, Dayton Children's Hospital, geneticist who has an interest in bone disease. I'm going to do something a little different. I'm going to start with a conclusion. Radiologists generally do things backwards, so if this doesn't make sense, you can go to the archives, I guess, and play my tape backwards. But here is a conclusion of my talk, and then I hope to spend the rest of this time in trying to defend my conclusions and supporting what I'm saying. I call this condition fracturing infantile rickets because it's probably a subset of the broader disease rickets. Rickets, by definition, is the inability to mineralize bone precursor in juvenile bones. First thing we notice is that there's a striking narrow range of age of presentation in these contested child abuse cases. Typically not before 1 month of age and very little, if any, after 8 months of age, and I'll show that graphic a little bit later. The rickets we're seeing is a specific form. It is not the classical forms that we see in older ambulatory children that present typically after 12 months of age. It is always in a stage of healing. We don't see the active disease. It is, by definition, it presents this young in life. It can't be chronic illness. So it's an acute form of disease. The ones with fractures often have multiple fractures with little, if any, physical contact spontaneously. And these appear to indicate that there's a severe fragility for a brief period of time anyway. It is a transient condition. It does reverse, and I'll tell you why. There's multiple etiologies. I don't think it's just a vitamin D issue. I think it's multifactorial. Prospectively, the clinicians, child abuse pediatricians, pediatric radiologists are not recognizing this largely. Even retrospectively, when our case is made in writing to the attorney, that this is generally denied as a possibility by the other experts involved. Caveat, you should know that my experience is quite biased. I don't work at a children's hospital. I'm not seeing cases that come into the emergency room or ortho clinic. I get my cases from the mail, and therefore the implication is I may be really looking at a rare disorder, a rare manifestation of a common disorder. And always I state in court and in my reports that when you see a fracture in a child with metabolic bone disease, they both can coexist. And certainly I'm not saying that these cases shouldn't be evaluated by experts in child abuse. It's also relevant as a radiologist to have an understanding what has the weight, what carries the greatest weight as far as the diagnosis. Now, as a radiologist, there's not a day goes by that I don't put in a report an x-ray finding and a differential diagnosis. It could be A, B, or C. Please perform test A, B, C, or D to narrow the differential diagnosis. But in some conditions, an x-ray is highly suggestive, if not, frankly, pathognomonic. And I believe rickets on an x-ray is pathognomonic, and it closely mirrors the pathology. On the other hand, particularly in a disease which heals rapidly and has a short duration, the clinical exam and the laboratories are much less important. So in my opinion, and I think this bears out in pathology studies, that the path and x-ray dominate diagnostic strength in the evaluation of these cases. And also, one of the main important points to understand is this is not the rickets that I was taught in residency, medical school, or my postgraduate training. Rickets has disappeared from our textbooks largely. Very few people know that because the textbooks and current literature is all they know about the disease. They haven't looked back far enough, and if you look at this example, Brenneman's textbook of pediatrics, which was Nelson's equivalent in its day over 50 years ago, a 100-page chapter, several hundred references in this article, and now Nelson's, which is the main textbook in pediatrics, 10 pages, barely half of that is nutritional rickets. Most of these are secondary forms. And it's this disappearance of the knowledge has occurred in radiology, it's occurred in pathology, and it's occurred in clinical medicine. So we really have to take a look at prior data. And even this quote I love from a pediatrician in Syracuse in 1975 said that rickets has become so uncommon in the 70s that even experienced pediatrician may not be able to recognize it. And if it was true in 75, it's probably even more true today. Okay, the summary of the cases. Now we're submitted a paper with regards to the fractures. The clinical paper is still underway. We're probably going to be producing a second survey with regards to the clinical features. But as far as what we've seen in the 63 cases, now I've seen over 400 cases. We stopped at 63 that had enough good medical records, and we tried to characterize what we're seeing. These cases, these children had on average nearly 8 fractures per case, up to 30 fractures per infant. By and large, other than the presenting fracture, most of these were healing and were asymptomatic, and they were missed by clinicians who were seeing the babies in the new baby, the postpartum visit and the well baby checks at 1 month and 2 months, for example. So most of these fractures were subclinical and found incidentally. We saw metabolic bone disease in all of these cases, averaged 10 radiographic features, and we looked at about 22 signs of metabolic bone disease. Rickets, hyperparathyroidism, etc. And some signs are non-specific, some signs are more specific. In all of these cases, the caregivers were low risk. They contested the allegations of child abuse. These were unwitnessed events, and sometimes a minor accident precipitated a unexpected fracture, for example, like changing a diaper or putting an arm in a car seat, and the parents describing a snap. Mode of presentation was usually symptomatic fractures, but again, another minor presentations, including petechiae, which occurred often in some of these cases anyway, a week or 2 weeks before, or subconjunctival bleed. Certainly not pattern bruises you see in child abuse. Now, this is really one of the most important slides, and this is one of the first things that struck me. We're not dealing with a random event, a random nature of violence, which can occur throughout childhood. This is a biological curve. I call this the 1 to 8, 2 to 4 curve, a range. We're seeing cases between 1 and 8 months of age. The peak is 2 to 4 months of age. And the case that we have that's depicted here at 12 months of age was probably an outlier. This was, I'm going to try out my little on-screen line here. Okay, it works. The 12-month child had severe deforming rickets, well healed, but the deformities persisted, and we're going to take quite a while to remodel. So no question that child had a peak of his disease earlier as well. So that's the first important thing. And I think I failed to mention the average age of presentation was about 13 weeks of age. Now, I would say that I never restricted the age of the consults I would look at when I'm contacted by a parent or an attorney. I didn't see any children after 1 year of age. I didn't tell them not to, but I just didn't. So it was really a striking age of presentation. Now, I want to contrast our presentation age distribution on top to that of a study done in Australia by Clements in 1943, which is a screening study of monthly x-rays for the first year of life. And then Elliott and Park's study should be 1925 and not 1929. Their study was done in New Haven, Connecticut, and they also screened cases clinically in the first year of life and radiographically. This chart is depicted in purple, is the radiographic findings. And what Clements found is at a time when the epidemic of vitamin D had subsided, public health policies were already initiated, fortification of foods and so forth, sun exposure was promoted, cod liver oil promoted, and about half the population developed rickets in spite of public health policy. And these were all subclinical. They were found incidentally in well babies on wrist x-rays. And look at the peak is exactly the same. The peak period is in these 2 to 4 month window, nothing after 8 months. Elliott and Park, on the other hand, did clinical and radiographic screening in those children. Even though this was in the height of the epidemic, the treatments started at Baltimore. at Hopkins, and these kids were already given sun exposure and cod liver oil. So they were already being treated. And in spite of that, so over 60% of these cases developed rickets when it was largely unsuspected clinically, but only discovered when they meticulously looked for it. So our age range is strikingly similar to the few studies that have looked for this in early infancy. Pathology studies have also confirmed this. This is again from the group at Hopkins, published in '52, which is clearly well beyond the era of epidemic rickets. They looked at 162 stillborns and found no cases of rickets. They looked at the first 2 weeks of life, which was really brilliant to break this down by age, and only one case out of 360 showed rickets at pathology. But using the same criteria for rickets at 2 weeks of age and beyond, there was an explosion in the discovery of asymptomatic subclinical rickets in dead infants with using standard histological evaluation of the ribs, costochondral junctions. And unfortunately, things didn't get better after '52, and there's been a handful of studies, and this is the most recent, done by our friends across the pond, Sheffield Children's, NHS Trust, Marta Cohen and her group, looked at a smaller number of infants, and they discovered, to their dismay, looking at ribs as well, under 1 year of age, 87% of infants had rickets, 100% of them if they're under 4 months of age. But using the same criteria after 1 year of age, none. Again, very small numbers, but it shows that this is an early life disease that resolves spontaneously. Okay, the characteristics of our cases now. Obviously, we'd be concerned about latitude of the pregnancy, since this maternal issues are very important in early life rickets. And there is a northern latitude predominance, a little bit of a male predominance, and twin was about 1 in 8, 1 in 9 babies had with twin pregnancies, which is certainly higher than background rate. Those are major risk factors for development of nutritional rickets and other diseases as well. And we had a little bit of a premature population. The mean age was 38 weeks at gestation. About a quarter of those were under 37 weeks of age. So not severely premature, but not what you typically associate with rickets of prematurity, for example, but nonetheless a premature group. It wasn't a predominance of dark-skinned individuals. Caucasians were 68% of our population. Season was not particularly interesting. Spring was the highest number, but it wasn't significant. Spring vitamin D levels are the lowest in the spring months in the northern latitudes, north of the equator. Again, atypical group with regards to feeding. We had exclusive breastfeeding in only one out of 5, and so formula or mixed, switching to formula shortly after breastfeeding terminated in the few months after delivery. So somewhat atypical. It didn't really matter. And this is quickly some of the characteristics of the infants. And infections actually traditionally is one of the most common ways rickets presents. If you look at the traditional literature, irritability, anemia, head sweating, developmental delay, failure to thrive, poor muscle tone are all very standard observations in childhood rickets. Things that might surprise you and surprise us: neonatal jaundice, hyperbilirubinemia of the neonate was very common. It resolved, but we don't know what the significance of that is. And reflux, and what you might not know, unless you looked at the old literature, is that reflux was a common symptom of rickets or vitamin D deficiency state. So traditionally it has been linked presumably due to the myopathy of the esophagus and pharynx, trouble swallowing, and that also bore out in more careful questioning of the patients. We didn't have statistics on it, but difficult feeding and poor suck reflex. And I would say that as we gather data on these cases and as we learn more and more about the disease, we're adding more questions to the database and looking more carefully. So this is why I think it's important to reevaluate another set of cases now that we have a much fuller idea of the range of presentations of vitamin D deficiency or rickets or both. Other things I would mention that skin conditions such as petechiae and dermographism, which is a reddening of the skin when pressure is put on the skin. Not a bruise, but it can stick around for hours or days and can mimic a bruise. Eczema, very common. Oral thrush was common in this population, but we don't have control groups, so it's a little hard to know the significance of that. Of course, we want to know about vitamin D, and what's more important, we really want to know about the vitamin D of mother, and because the mother's going to influence what baby is born with. And The average is at the cutoff for deficiency, insufficiency, about 20 nanograms, slightly under. 68% were under 20 nanograms per ml, so reasonably deficient, but not severely so. Now, this is the mother's levels, just to remind you, what do we know what the baby should have? The baby typically in population studies will have between 60 and 85% of mother's levels, so it's usually lower, average about 70%, and there's 4 example studies and graphs I copied to show that relationship. There is a very strong relationship nonetheless between mother and baby. Well, here's what the infants that had measures, 36 of them had 31 nanograms, and we would have predicted it would have been well under 20. Why is that? Because the babies didn't get measured, vitamin D measured at birth. They got measured at the time of presentation, which was about 13 weeks of age, and many of them got blood measures a few months later. So they didn't get measurements typically in the first few months of age, which implies that you would predict their D levels were lower than mothers at birth and rose. So the natural history, I would pose that as a question. Does the natural history of vitamin D in infancy, is that of one continually rising? And the answer to that is yes. And these are a number of studies who looked at children in the ages which represent these yellow bars, and I picked and selected data for the first 9 months of life which matched our population. And you can see in the red boxes that the amount of increases of vitamin D from the period of entry to the period of termination of their observation period was about 2.5-fold. It's several times, 2 to 2.5 times in the first 9 months. So if you look at the cumulative effect from birth to 9 months of age, you may easily be looking at some individuals at 3 to 4-fold rise in vitamin D. So when we observe healing rickets on X-ray, the natural history of vitamin D is that of substantial rise in the first year of life. Then we have a confirmation. In other words, it validates our observations. Okay, and this is basically the situation I believe we're seeing. And I selected a couple studies here. There's 3 studies that looked at Caucasian mothers, and their vitamin D levels hover around the 30s. These are more recent studies in North America, and ours were about 30% lower. The natural history would be that the babies could be born with about 70% less, and then they're going to rise after that till about the 3-month when they present with fractures. And we had one case which we were able to get blood at birth and do a spot check on it, and it basically followed this exact pattern. So this is, I believe, precisely what we're seeing, and I think that's why it's important when you evaluate an infant with multiple fractures, test the mother. Much more important than testing the baby. Okay. What's the average D level in America, in the United States, that we see associated with rickets? We don't know in infants because it's not been published, but we know in older kids. And these children average about 13 months of age. DeLucia, I believe it was a Yale study, and Chapman at Seattle's children, about 21 nanograms per ml. But look at the variability here. You can see that we had levels of up to 55 nanograms here and 74 in the other study. So there's really, and we've known this for decades, that there's no vitamin D that will predict or assure that you're going to have rickets, and there's no vitamin D high enough that will assure that you won't get rickets. It's multifactorial. It's a balance between calcium, vitamin D, and probably a number of other factors as well. Okie doke. I did select a couple of studies because one of the questions I had is, what happens in the first few weeks? Is the birth level the very lowest, or is there any evidence that it actually gets lower after birth? And I think the answer to that is very possibly. These are, I just copied sections of graphs from 3 studies that looked in the first 8 weeks of life, and you can see in several of these studies they showed declines between birth and 6 to 8 weeks of life, and Chala only had a decline in the seasonally unfavorable, infants born in the seasonally unfavorable period of time, as opposed to when they were going into a period of sun exposure. So even in early infant, sun exposure apparently made a difference. So basically what could be happening then, if mother is deficient, baby is born more deficient and can get even more deficient in the first 8 weeks, or a nadir can develop in the first 2 months prior to rising. And by the way, I want to emphasize one other thing. In these studies I showed you, most of these were breastfed. So even on breastfeeding, the vitamin D levels are rising substantially. And you would predict, which appears to be the case, on formula it's going to rise even faster. Okay, the other labs weren't really that valuable, and that bears out in studies of Rickets prematurity and early infancy. Labs generally aren't highly sensitive or specific. Alkaline phosphatase was high in about a third of our cases. Parathyroid hormone rarely even ordered. Serum calcium, that should be phosphorus, can be low, normal, or high, and they typically are normal, but we had a few percentage in the high or low range. 125 dihydroxyvitamin D is actually perhaps valuable. It was elevated significantly in a number of cases, and that may be, it's been reported as a sign of healing rickets, or when you give vitamin D to an osteomalacic adult or a rachitic child, 125 is upregulated. So that may turn out being valuable. One of the other characteristics of the mom, and I put this under the category of risks for vitamin D deficiency or fetal bone impairment, and most of these wouldn't surprise you. We have moms that avoid the sun, avoid dairy. A high percentage have BMIs over 30, avoid prenatal vitamins, mostly because they haven't been told, or they have such bad reflux and nausea issues during their pregnancy, they simply couldn't tolerate the taste of vitamins that made them nauseous. Reflux, extremely common, and very high use of Tums. And the mothers, and it strikes me, even beyond these 63 cases and the few hundred I've seen since, the mothers are taking Tums hand over fist, and nobody is telling them to restrict their use or using it ad lib. So very high percentage of these mothers are taking way too much Tums above label recommendations. Tobacco use is surprisingly high in this group. Asthma, which can be a risk factor, particularly on medications that can impair bone metabolism. The question on Ehlers-Danlos, and this could be an exclamation mark and not a question mark. In the last 6 months, we've started more earnestly assessing some of these cases, and we find a strikingly high prevalence of Ehlers-Danlos in mothers. Now, these have been seen by geneticists across the country. It's way above background rate, and even though we don't have a control in this group, it may be as high as 10 to 15% of these cases. We know one of the features in Ehlers-Danlos is skin laxity and joint laxity, and believe it or not, those are described in vitamin D deficient osteomalacia. So if the mom's had osteomalacia, it's possibly that there's an overlap between the clinical features, but nonetheless, this needs to be explored further. So the signs of blatant D deficiency in mom, and there's some overlap between signs and risk factors here. Nothing surprising: anemia, preeclampsia, hypertension, symptoms of osteomalacia. We've had either some of the moms have been on narcotics with severe musculoskeletal pain, muscle weakness, muscle pain, depression, prenatal or postnatal, gestational diabetes. A few other findings that we added late in our data accumulation that's been reported in D deficiency literature in pregnancy: bacterial vaginosis, gum bleeding. Just as an antidote, my wife had three pregnancies. She was taking the prenatal vitamin. The first two had severe gum bleeding. The first two pregnancies. On the third pregnancy, she was taking 5,000 IU a day, had absolutely no gum bleeding whatsoever. So that could be antidote, but gingivitis is reported to be strongly associated with vitamin D deficiency. The pregnancy, the delivery process of the pregnancy characteristics itself, these are also linked to vitamin D deficiency. C-sections, failure to progress, preterm labor, high prevalence of twins, malpresentation such as breech, decreased fetal movement. Don't know why it's so common. It's reported that may be a risk factor for bone development, maldevelopment, of course, fetal loading, very important, but it could be a myopathy. You don't think about fetal myopathy with maternal vitamin D deficiency, but it's plausible. In fact, C-section due to failure to progress is a uterine myopathy, same as osteomalacia myopathy of mother. Don't know, something to ponder. Okay, the X-ray spectrum, what we are looking at is the combination of rickets. Now, when rickets affects, by definition, rickets is a disease of the ends of the bone where endochondral bone growth is occurring, and it also affects the bones that aren't contributing to bone length. So the term appropriately should be rickets/osteomalacia, but I'll just use the term rickets to describe both of those situations. and you can get secondary hyperparathyroidism. Those work together. Hyperparathyroidism is an independent risk factor for bone fragility. But basically, there's three things we look at in metabolic bone disease. Mineralization abnormalities, we look at deformations. Some people consider deformities to be microfractures, others do not. And then frank fractures. Of course, multiple fractures in various stages of healing is considered to be highly specific for child abuse. But when you think about it, if a child has fragile bones, you would expect him to have multiple fractures in various stages of healing as well. Okay. The important thing to understand, I believe, is the mineralization sequence and the failure of mineralization sequence. Typically, when the inability to mineralize, whether it's a growth plate or trabecular bone or cortical bone, when that process is interrupted, excess precursor is produced, not just the normal amount of precursor. And there's two precursors, osteoid and matrix, which is the protein-rich precursor of bone. And in an acute process, obviously, mineralization may be completely normal. If it has a period of time, it could be under-mineralized. But during the healing process, because of the precursor bone is produced in such excess, you actually get hypermineralization. So it might actually look much whiter than expected. So the washout or osteopenic of bone doesn't necessarily occur. In fact, it shouldn't occur when there's a recovery phase going on. Now, this is one of the main radiographic findings that have supported diagnosis. And this is an animal study which formed the basis of how the bones heal. The end of the bones heal so predictably, and this is an animal study by Dodds and Cameron, that a commercial test was devised. So if a manufacturer of cod liver oil wanted to know how much anti-rachitic activity was in this bottle, before they had vitamin D assays, they would produce rickets in a lab animal, give them the cod liver oil, and take serial x-rays. And the healing was so predictable that it was put in stages, and it was called the line test, L-I-N-E, line test, commercial test for over 20 years. Here's a close-up of the stages that we characterized. And stage 1, when you have thickening or excess cartilage in the growth plate, excess matrix, when you start mineralizing, a line is produced. I think I've got a little red here. Okay, this little white line that floats above the growth plate would be the first sign of healing. This is a characteristic pattern. They're all not characteristic, though. But this little white line here floats above, and it usually extends all the way across. When healing progresses, it's almost like a window shade is pulled down. You'll get progression of the mineralization front from the epiphysis, which is up here, to the shaft or metaphysis down here, until this becomes a matrix cap or white cap of bone. Once this cap is in contact with the metaphysis where the blood vessels are, the blood vessels invade and remove a lot of this mineralized matrix. This area is smudgy white. It is not trabecular bone, not yet. When blood vessels invade, trabecular bone is formed in the walls of the blood vessels. So you go through a period of time where it is darker, actually. So you have loss of mineralization before it normalizes. And we found in stage 1 in 38%, stage 2, 2/3 of the cases, stage 3, and 44%. So overall, stage 1, 2, or 3, which is radiographically distinguishable, almost 90% of these kids had pathognomonic signs of rickets. So it's really extraordinary. And it wasn't uniform. Rickets doesn't have to be uniform. It usually is quite asymmetric. And it's more affected. There's a preferential involvement of bones which grow rapidly. Okay. And here's some examples of what I call staged rachitic healing. We go from stage 1, and you can see the line test, line here floating above the bone, and now it's a matrix cap, where there's just a cap of bone. Right here is the cap, and you can see these black arrows are the white line. This is the original zone of provisional calcification. This white line is where the bone, the growing front, should be in the bone, and this is the width of this zone here. The matrix cap tells you how long the rachitic process occurred. So this is a stage 1 to stage 2. Here is what looks normal, but actually it was rachitic. Histologically must have been, because 3 weeks later, now we have a matrix cap. We see the old and the new zone of provisional calcification here. The third example, again, is dense matrix cap. And the old zone of provisional calcification actually shows up better once vessels have invaded and are removing some of the mineralized matrix in the growth plate, which is here. And stage 3 to stage 4, which is basically recovery and trabecular bone now forming. So these are pathognomonic sequences we're seeing in these cases. And this is something I certainly didn't learn in my studies. This is what, certainly this is in the pathology literature, but there's not a lot of this actually in the radiology literature. It's there, but it really has not been emphasized. You get this sequence in vertebral bodies as well. This individual, in just it was a 6-week interval of time, here's the vertebral body. You're starting to see bone in bone, so you see a matrix cap on the perimeter of some of these vertebral end plates, and it's even more prominent later on. There's the matrix cap here. So look at the distance between the vertebra. Okay, quite a bit. So the vertebral bodies are essentially getting bigger. They're not really getting bigger, just the unmineralized matrix that's engulfed it during the active stage of rickets is remineralizing. So rather dramatic bone-in-bone appearance in sequence. This is very few times in the published literature do you have multiple serial x-rays, and this was a good example in a textbook, 1980. You can see the line test here in the tibia. There's the line stage, okay, and then the matrix cap has occurred, and now this area is loosened. Here's the original zone of provisional calcification. You can see it here as time goes by. And there's also some healing from the metaphyseal. So you don't always heal from the epiphyseal side. You can heal from the metaphyseal. In this case, to the femur, you can see the zone of provisional calcification, which normally marks the end of a bone. And this isn't the end of the bone because you have this stuff on the other side of it. That's all remineralized rachitic intermediate zone, and this eventually fills in from this direction. Sorry for my crookedness. It fills in from the metaphyseal side and not the more characteristic way from the epiphyseal side. And finally begins to remodel, but you can still see the original zone of provisional calcification here, and the rachitic intermediate zone is starting to look more and more normal. All right, I call this the jump rope sign. This is just highly striking when you have the zone of provisional calcification, which is the new one at the early onset of healing, joins this structure, these little vertical spikes that come out at the end of the metaphysis. And here's a case of child abuse. This occurred when the child was in the hospital, had not gone home, and broke ribs in the hospital spontaneously. And this is a case from a French study, 1930, same thing, very striking similarities. Jump rope test, what makes the vertical part of the jump rope? And that's the perichondral ring. Perichondral ring is a normal anatomical structure that's usually invisible on X-ray. It surrounds the growth plate much like a cigar band does on a cigar. So this is looking down the barrel on the shaft. This is looking as you would take an X-ray of the long bone, 90 degrees or perpendicular to the long axis. You can see the thin perichondral ring here. Now it is circumferential, but even on a specimen radiograph, you only see it on the sides. And why is that? The X-ray beam is coming in here, and you're shooting through tangentially quite a bit of the ring. But when you shoot the beam here in the center, there's not enough ring thickness to show up. Just like cortical bone, you don't see this on a frontal X-ray. So it looks like it's something on the right or left side of the bone or the front or back of the bone, but that's a circumferential structure. That's just a manifestation of the X-ray. You do see it as a ring if the epiphyse slips. And here's a great example of a symptomatic ankle infant who was getting diaper changed, and they noticed some pain and swelling. The ring has rotated, and it should be fitting here and here, so it's rotated to an off position. What the perichondral ring should look like, you can see on the fibula, which is intact, is a little spur, a little spike that fades as you go centrally. So same structure. This is displaced. This is non-displaced. Okay. Kiddoke. This is a histological specimen of a thick perichondral ring, and it should be 1 or 2 chondrocytes thick. And I've got my whiteboard here. Okay, these are chondrocyte rows, 1 or 2 rows thick. That's how normally thick the perichondral ring should be, and it overproduces during the active phase of rickets. So when it heals, it's going to look like a big, chunky spur along the side of the bone. Okay. Important histological fact is that the bone bark or the perichondral ring isn't continuous with the rest of the bone. Why is that important? Because it can look like a fracture. this little cleft that you see in the medial perichondral ring, not present in the lateral perichondral ring, is a normal anatomical cleavage. This is the perichondrium. Periosteum is along the metaphysis, and these aren't necessarily contiguous, and they can be separated by quite a distance. Okay, so this little crack is not a fracture. Okay, so let's put all this together, and this is what I would consider a classical rachitic healing sequence. This is a 2-month-old with leg swelling, and the first thing you will notice is that if you draw a line in the shaft of the bone, the epiphysis is offset. This is a slipped epiphysis. Okay, so this is why this infant had knee swelling. Now, it could have been abusive, yes. Could it be spontaneous, yes. In rickets and scurvy, the growth plate is prone to slippage, so you can get these symptomatic, abusive, traumatic-looking lesions, which are just part of the natural disease. Let me zoom up on these 3 series now. So here's the offset that I described. This is the tibia. This is the original zone of provisional calcification, which is indistinct. So active rickets is here. There's no zone of provisional calcification. And to show you what it looks like a few weeks later, this is about 4 weeks later, you can see the sharp white line in the third image here below at the bottom. So that's remineralized. Here's the line test positive. This is perfectly parallel to the growth plate. This is the new zone of provisional calcification. And this is the perichondral spur. This can be confused as a fracture, but it's attached. So you have the new zone of provisional calcification hooking right into the perichondral ring. You can see some periosteal new bone on the third image along the shaft. This is from bleeding from the slipped epiphysis, and then that's healing. So this is a tremendous sequence. And look at the epiphysis. Actually, the top is smaller. The one down here now, it has a bone in bone. The original epiphysis is here, and it's surrounded by a thick rind of new bone as the excess osteoid around the epiphysis has remineralized. So all in all, classic pathognomonic changes of rickets. In this case, I found in the literature, in a let's see the date. Well, I can't see the date, but off the top of my head, it's the 1960s or so, 1950s, paper by Frederick Silverman. And this is considered to be one of the hallmark papers that established these changes to be actually abusive and not rachitic. So this is just one of many examples of rickets that you'll find in the child abuse literature that I have found. And it's sad, but nonetheless, this is a pathognomonic sequence. Okay. I'm not going to go over, obviously, 22 radiographic signs today, but I want to show you a couple striking ones that we rely upon, and radiologists of yesteryear and clinicians of yesteryear rely on quite a bit. Because the skull is one of the more rapidly growing bones, if not the most rapidly growing bone in the third trimester, what we have is a skull that is susceptible to develop rickets. Rapid growing bones more susceptible to develop rickets earlier, and more severely slower growing bones don't. And there's 2 manifestations. One of them is widening of the sutures right here, and this should be a line about this thick, and it's much thicker, as you can see, and the margins are very indistinct. So this is where new bone is formed, failure to mineralize the new bone. You can see it on CT scan here, this gray band along the sutures. This is parasutural demineralization, but the other finding is these holes in the bone, seen much better on CT. Multiple bilaterally in the back of the skull, lateral and occipital sides. Craniotabes is the term, and this corresponds to parchment paper type of palpation on clinical examination. So very characteristic findings of rickets. Very important to look for this in early infancy. Here's what a skull looks like, a gross specimen, and this is a skull on a light table. These thin areas, parchment paper, like thin areas where light is transmitted, and obviously these holes. Now, some people have claimed that craniotabes is nonspecific. Well, if it's an isolated finding, there's no other findings of rickets whatsoever. That may be true if it's mild, and this is what people at Hopkins, Martha Elliott, Edwards Park had said long ago. However, the studies that are well designed and look for associations between craniotabes, and they look for vitamin D levels, season of birth, breastfed versus formula-fed, ALK phos, parathyroid levels, and so forth. And these studies consistently find that there are other associations with craniotabes. So it appears to be, it can be in a very mild form, it may be normal, but we're never seeing this as an isolated finding. and I would consider it always abnormal. Okay. And it is such a reliable early sign that the researchers in Japan relied upon this to look at screening studies in newborns. And this is very frightening. This is a much southern latitude than most of the United States. In Kyoto, Japan, they did physical exam and ultimately some wrist films, and they found about 1 in 5 babies have craniotabes in the first week of life. It decreased by their 1-month follow-up. So again, follows this pattern. Somewhere between 2 to 3 weeks, it starts reversing. So this is subclinical rickets, and they've correlated it with vitamin D level season of birth, rapid response to vitamin D repletion, and so forth. Okay, and here's some more examples of craniotabes in the Rickets literature. Holes on a 2D and 3D reconstructions in the gross specimen, and some of our examples here. So pretty characteristic, quite striking actually. Changes in shape of the skull were very common because the baby has a big head, soft skull, and lays a lot. So you really want to look for deformations in the skull. A normal skull, round, not my round, but that round, and then here you can see square-shaped head. Caput quadratum, which really it should be a clinical term, not a radiographic term, but you can see the match here to a rachitic child from the literature in one of our cases. And I was lucky enough to find a infant who had a vitamin D level drawn at 3 months of age, was on a Weston Price raw milk formula, and taken 1,000 units of vitamin D. 72 nanograms per ml, robust. Rounded back of the head, and this is a typical case we see, very low vitamin D, and you can draw a straight line on the back of the skull and see the occipital flattening. I would say that when you go to the grocery store and you see babies with flat skulls, it's not a good idea to talk to the moms because they get a little sensitive about it. So you will recognize a lot of flat heads out in the population. You kind of wonder if they're vitamin D deficient. Another really unusual thing that we saw in these cases was bowing of the other joints. Now, they're not ambulatory kids. We don't see genuvaris or genuvalgus, knock knee or boat knee, but we see this, proximal ulna bowing here in 13% of our cases, and 43% of our cases, the distal tibia bowed medially, and this was a Sabershin deformity, which was well known in Rickets. And here's an example in the middle. These two cases are not my cases. They're from the archaeological literature. So the archaeological metabolic bone disease literature is very valuable because you can see the gross bones, the changes of rickets in the gross bones, and you see absolutely mirror image changes in these known rachitic specimens as we see in our typical cases. Okay. All right. So basically, how is rickets being misdiagnosed as abuse? In these contested cases that we see, there's 3 possibilities that we consider. Are the fractures due to rickets and therefore bone fragility? Is it an accident that happened to be a pressure, happenstance force to fragile bones? Or was it real abuse? And all those are possible. I've only seen one case of real abuse, and it was very, very minimal rachitic changes, nothing like the typical case we see. So most of these cases fall in these first 2 categories. These are kind of the in-betweener categories. How do you evaluate these? Was there enough force to produce the fracture? If a father or a caregiver is angry and grabs a child and ribs break, but the ribs are fragile, is that abuse? So I'm glad I don't have to make those judicial decisions, but there is some gray zones that have to be considered. So we obviously were looking at the basis for these fractures in rickets is fragile fractures, in other words, insufficiency fractures. And there are also some pseudo-fractures, which are characteristic of fragile bone states. The first, many of you have heard of, those are looser zones. I'll explain what that is in a minute. We have see these in over a quarter of our cases. And the other pseudo-fracture I consider, which is controversial, but something that's known in the child abuse literature as highly specific for child abuse, or a CML, classic metaphyseal lesion, is my opinion, is a pseudo-fracture, and in fact is a marker of rickets, healing stage rickets specifically, and we see that in 65% of our cases. Looser zones are transverse lines into the bone. In an example, in an adult with osteomalacia, a child with rickets, transversely oriented fracture with respect to the long axis of the bone. The gap is wider than a normal fracture, and there may be sclerosis at the margins, or this whitening. So wide gap sclerosis transverse. Here's an example of looser zone in the child abuse textbook, and it's easy to find these. They're all over the place. And looser zones occur sequentially in ribs, just like they do here. Two adjacent ribs, two adjacent ribs. These are attached with muscle, so you'd expect fractures to occur in lines. And here's a paper published in Pediatric Radiology not that long ago. Forgot all about looser zones and basically called it a hole in the rib sign. So we truly have forgotten what a lot of metabolic bone disease looks like. The CML hypothesis was put forth by Dr. Kleiman at Boston Children's, and actually he's the only author of this study with regards to basic science. And the hypothesis was that a fracture line occurred in the metaphysis just below the growth plate, and it appeared as a bucket handle if you look straight on, and if the X-ray beam was angled, you would see a corner manifestation down here, corner fracture only, and you would lose that. And this is my laboratory experiment I did in my kitchen with a carrot, and this I didn't get blown up here, but if you shoot, look straight down the barrel, you see a white line. You're shooting right through it, but if you angle your X-ray beam through the carrot like this, you only see the corner part of it. And that's, as far as I know, that's the only study ever done in my kitchen this week that confirmed positional changes could affect the way a transverse line looks like at the end of the bone. But these are the two major, there's about 9 studies that all performed by Kleiman, who's a pediatric radiologist, and Sandy Marks, who is a PhD researcher. Looked at these tissue, looked at these in 31 dead infants. The age of these kids were in what I call the danger zone. This first few months of life, the children average age was about like ours. And they, in many of these cases, they had no reason to believe these children were abused. Took x-rays and looked at the pathology of these lesions in the bones. And as you recall, I showed you a study in the UK by Marta Cohen and her group. 87% of kids in the first year of life have rickets at autopsy. None of the cases were reported to have rickets in Boston. And would they even know at the time they did this study that there'd be a high prevalence of rickets in their population? They probably didn't. So in my opinion, they were looking at rickets rather than child abuse. And it's not just an opinion, it's based on what they reported. I would invite you to take a look at this abstract or pull the paper, and if you want a copy of it, please email me. I'd be happy to send you a copy. Published in January of this year, our conclusion was that the CML hypothesis as an abusive lesion is poorly supported. The histological and X-ray features are similar. In reality, they're identical to healing rickets. And they've never been reproduced experimentally, not in an animal study, not in a human study, and they don't occur in accidents, trauma. They're specific to children who are being abused, who are being accused of being abuse victims. So they're really strikingly odd lesions that have not been reported prior to that period of time. And I won't go through this, and I will invite you to look at this paper. There are 17, if you add the carrot work I've done now, 18 reasons why the CML is actually a rachitic lesion. Time will not allow me to produce that, but I'll show you 2 examples in our time remaining. This is the this is the corner fracture type, and this is hypothesized to be a fracture, these little spurs. This is from Dr. Kleiman's paper. Here's a paper from John Caffey and Rickets, and you can see the exact same spurs. The hypothesis is that the X-ray beam was off angle, and there was a transverse fracture through the entire growth plate, but it was hidden when you angled the X-ray beam or the leg. But notice this characteristic indentation right here. Let me clear that board here. Okay, this characteristic indentation on both sides histologically was excessive hypertrophic chondrocytes. And that is a hallmark feature of rickets, and not only that, you get it in this location in rickets, you don't get it in trauma. You get excessive proliferation in the central part of the growth plate during traumatic disruption of the blood vessels. So this was a rachitic pattern of healing, partially healed rickets. The bucket handle form of the CML, here's the line above the growth plate. Notice there's multiple Parkeris lines here, so stop and start rickets, sclerotic and lucent lines. And here's a case from an earlier example I showed you, and here's the bucket handle right here. And you can even see this is turning down into a thickened perichondral ring. So this is pathognomonic sign of rickets, not abuse. Now, unfortunately, the American Academy of Pediatrics has relied very heavily on this over several years, really since Kleiman's work. And in February, prior to their knowledge of our paper, they had noted that the CML is highly specific for child abuse. Okay. And how common, and this, it becomes a relatively important question. I have a very biased sample. I don't know, what I'm seeing might represent 0.1% of all child abuse cases. I have no way of knowing because I don't work at a children's hospital and I'm not screening cases through the emergency room or an ortho clinic. So I picked up one of the atlases of child abuse that had cases, and so it presented us by cases rather than process. And there were 35 cases of fractures, and this is a group out of Houston that wrote the book, and CMLs were seen in 8 out of 35 of these cases. 20 out of 35 had signs of metabolic bone disease. So radiographically, half of the cases had signs of metabolic bone disease. And now this was only single x-rays. I'm not seeing full body skeletal surveys. So it's dramatic that 8 out of the total 35 had CMLs, which are, in my opinion, highly likely these are misdiagnoses. The age is also telling. In the cases of metabolic bone disease, which was the majority, 75% were under 9 months of age, only a quarter of those cases with normal appearing bones. And many of these group would be moved here probably if I had full skeletal surveys and had other opportunities to recognize metabolic bone disease. And I think with that, I want to leave some time for questions. So I will stop there, and we've got about 9 minutes left. And I would invite you to write me, email me on my personal email address. I'd be happy to send you some information, anything specifically that you would like. And I'd also encourage you to go to the website for CME credit and CE credit. Thank you very much. Okay. Well, I don't see any questions, so I could fill in the last couple of minutes with a couple of slides that I skipped over, if that's all right. Let me just ask the moderators if that's okay if I go on for another 8 minutes. I think I will. Let me check for questions one more time. No questions? No problem. Okay. Well, why is rickets occurring? This is one of the, I think, important reason. If you look at the growth rate, rickets is going to develop in faster growing bones. And this is a standard pediatric growth chart. I'm drawing these lines on the vertical rate of growth. And the slope of this line indicates the velocity of growth. So in the first 3 to 6 months particularly, it's an extraordinary rapid growth period. So these infants, regardless of their D situation or not, are going to be highly susceptible to developing rickets in this first part of infancy, just by growth alone. Fascinating study. You need to be able to absorb fat, to absorb vitamin D and vitamin K, for example. And this is a study done in the Netherlands by Van den Nucker. He looked at complicated graphs. I'll explain it. In preterm babies, they noted through a proprietary test, basically how much fat was in the stool, that 60% or more of the fat ingested was not absorbed by preemies. We know preemies have issues with fat-soluble absorption, but the full-term infants were on this side of the line, and look how many full-term babies in the first 6 months don't absorb fat-soluble fat very well. Normal is considered in the 10 to 15% range down here. So a subset of full-term babies don't absorb for whatever reason, liver maturity, and so forth, don't absorb fat-soluble vitamins. This may be superimposed to growth rates in maternal vitamin D. The other issue is, how are we doing with the vitamin D supplementations? And this is a very concerning report by Perrine, published in Pediatrics. If you look at the first few weeks of life, up to 6 weeks of life, and babies, the question was answered, who's taking supplements? On formula, 1% of babies were on supplements. Breast milk, those that really need it, 5% are getting supplements. So it doesn't matter, there's debates on how much we should give. It doesn't matter. If the babies aren't taking what's recommended, it might as well be 10,000 units a day that's recommended. I only wish that vitamin D was a vaccine, because we have high compliance with vaccine, certainly not with vitamin D supplementation. And they also calculated the intake, accounting for what was in the milk, what was in the formula, what was in oral supplementation. So how much were they getting, all sources, in these first few months of life, and these are based on the 2008 AAP recommendations. 11% were getting the recommended overall, 5% on breast, 25%. So 75% of infants in early infancy are not getting what we know is important for bone health. Okay, and lastly, one of the, I think, the tragic things that have occurred, and sometimes when policy changes so slowly you don't notice it. It's like the boiling frog. If you look at who was giving the recommendations for maternal and perinatal care in the United States, it took the role of the CDC or the AAP. Since about 1914, it was the Children's Bureau, which is Department of Labor. This was headed for a long time by Martha Elliott at Johns Hopkins, who's a Rickets expert. They recommended, look at these recommendations. This is a 1931 document on sunshine, giving sunshine to your baby. They knew that cod liver oil and sunlight prevented rickets. They also recommended after a month or two, babies should be getting a half hour a day of sun twice, 2 times a day. Now that recommendation shortly after this was moved up starting in the first week of life. So at the end of the first week, babies were getting sun baths already. And cod liver oil was given twice a day, which is the vitamin D supplement equivalent. Over time, this is their policies in the 60s and 70s, and this is a cryptic note, a Venetian blind being pulled on the sunshine. I have no idea why they chose this logo. They really downgraded their enthusiasm, didn't they? It's good to relax in the sunshine, just don't overdo it. In the 1980s, it was pure hogwash, in my opinion. There's nothing magic about taking your baby outdoors, and if you do, cover them up. And almost looks like carpal pedal spasm in this cryptic image as well. But clearly we've had a dramatic change, and the AAP has followed suit with this document in 1999 August. Ultraviolet light, a hazard to children. And their recommendation was infants under 6 months of light, no sunshine. Dress up the kids, and be rigorous in sun protection, which doesn't block vitamin D production. And we know this is completely untrue. Sunblock does impair vitamin D production at the skin level, no question about it. What happens when we reverse policies that prevent disease? You would predict that the disease would recur. And this is exactly what appears to have happened. 3 different studies, 2 in the U.S., U.S. studies, and this UK study. About the time AAP's policy kicked in, 1999, look what happened to the rates of rickets after this. Now, is that a coincidence? Yeah, it could be. But you know what? It's pretty predictable that something like this would happen. And it may be another 10 to 20 years before clinicians wake up and catch up to the disease that we've forgotten. And I really think that we have. And with 2 minutes to spare, I think I am done. The Stowe-Cohen study do iliac crest biopsies. I'm sorry, for some reason I'm not. Oh, there's the question. Sorry, Marta. Marta Cohen. Rosalina Hansen. I'm not sure who the asker is, but at any rate, Marta Cohen did not do iliac crest biopsies, and I think it's a good thing she didn't, because you have to look at the rapid growing bone. And so in an infant, you have to look at the skull, you have to look at the costochondral junctions, and then you have to look at the extremities. But you have to look at those portions of the extremities which grow more rapid. So a rib is a pretty traditional way to look for rickets at the growth plate because it is rapidly growing. Now, if you find it in the rib, it doesn't mean that it's everywhere in the body. You want to look at the susceptible bone. So it is among the more susceptible sites. It is traditionally the site that's tested, and she looked at the histomorphometry of the growth plate, and she's doing further studies now looking at other things like excess trabecular osteoid, if that's what the question implies. But we've certainly seen radiographically evidence of excessive osteoid, and one of the features that we saw is sclerosis of the trabecula, thickened trabecula. In some cases, the trabecula is so thick you can't even see bone marrow space between trabecula. And heterogeneity of trabecula. This has been described in recent histomorphometry papers where they've, through automated programs, have measured the heterogeneity of trabecular width or thickness, or the population of trabecula in the bone, and a very common finding. They didn't actually report it because it was somewhat subjective, but we saw very characteristic, and I see this in adults as well. Some trabecula are sclerotic and thick, and others are atrophic and diminutive, and all in the same growth region. So to answer your long answer to your question, no, Marta Cohen did not look at that. Should bone biopsies be done before a child is taken out of the home? Well, you can excise bone or you can excise a child. And if it was my child, I would rather you take bone than the baby. But, you know, these findings are pathognomonic. I mean, do we have to reinvent the wheel? We've already proven that the changes we're seeing on X-ray are pathognomonic for rickets. So let's just relearn what we've forgotten. No, we don't have to do biopsies. If that'll save a family from being blown up, yeah, let's do that. But that may be less painful to the pediatric radiology community at AAP, which is really, I think, very remorseful and going to be remorseful if I'm proven right. And thank you very much, and have a pleasant day. Enjoy your conference.